Live, Chairman.
Good afternoon and welcome to West Berkshire Council's Health Scrutiny Committee. I am Councillor Alan McCrow, the Vice Chair of the committee. Other members of the committee are Councillors Tony Linden, Andy Moore, Graham Pass and Jeff Beck. There's some council officers and external partners are joining us to advise us this afternoon. It's Paul Coe, who's Service Director, Adult Social Care, West Berkshire Council. Sarah Webster, Executive Place Director, Berkshire West Place from Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board, otherwise known as Bob. Will Orr, Chief Medical Officer, Royal Berkshire Foundation Trust. And Sarah Deason from the Advocacy People. From STAMA, Catherine Woolley, Children and Families Programme Lead. From Berkshire Healthcare NHS Foundation Trust, we have Rebecca Gimmery, I hope I've pronounced that correctly, who's Children and Young People and Families Lead for School Year Services and Interim Head of Children's Community Services. From NHS England, Hugh O'Keefe, Senior Commissioning Manager, Dental, NHS England, Bob and Frimley. Frimley is another integrated care service. David Chapman, System Clinical Lead for Pharmacy, Optometry and Dental Services. Sue Whiting, Deputy Director for Direct Commissioning Service Delegation. And Nilesh Patel, Chair, Thames Valley Local Dental Network. Vicky Phoenix is our clerk for the meeting. The meeting is also being live streamed via YouTube, and Gordon Oliver is the Zoom host. Before we start proceedings, I'd like to explain for the benefit of members of the public who may be watching that today's meeting is being held both over Zoom and with councillors present in the meeting room. The meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. During the meeting, I would ask that anyone wishing to speak raises their Zoom hand. All voting will be done by a show of actual hands. If we hear the evacuation alarm this afternoon, must leave the building immediately via an emergency exit. The assembly point is the Dolphin Pub car park. If the lockdown alarm sounds, we will remain seated and await instructions from officers. We will adjourn the meeting until such time that it's safe to proceed. Does anybody have any questions before we proceed?
Thank you.
So the first item on the agenda is to elect a chairman of this Health Scrutiny Committee for the remainder of this 2022-2023 municipal year. Are there any nominations for chairman, please?
Yes, I'd like to nominate Councillor Graham Pass.
Are there any seconders?
Chairman, I'd like to second that.
Thank you. Are there any other nominations? There being no other nominations, I declare that Graham Pass is elected chair, and we will. Oh, that's right. And I will hand over the meeting to you.
Thank you, Councillor Macro, and thank you everybody for your support. I am new to this. I did have quite a few connections with health, being on West Berkshire, in fact the Newbury District Council representative on the West Berkshire Community Health Council, which involved a lot of working with health authorities, I will call them in a generic term. But please be gentle with me with the acronyms. I worked in the aviation industry, which is full of them, but they're all different here. So if you could just spell things out, I'd be most grateful. But thank you for your support. I believe, Councillor Beck, you can't stay with us for too long, but thank you for coming anyway. So the first item I come to, item 2, is apologies. Vicky, I take it for a moment.
Well, we've received some apologies from Andy Sharp, West Berkshire Council,
right,
and also Andrew Sharp from Health Watch West Berkshire. Sarah Deason from the Advocacy People is here in Andrew Sharp's place.
Right, thank you very much. I take it no one knows of any others. No? Right, minutes. The minutes are in the agenda, starting on page 5. I wasn't here for the meeting that please record, so I trust you to raise any points that you wish to raised before I ask if I may sign?
On to raise, I'm happy to propose them as a group.
Okay, does that find a seconder? And those in favour, please. Right, thank you very much. Right, we come then to item 4, declarations of interest. Members, members or anyone present, any declarations of interest, please? Shakes of heads, so no declarations of interest, thank you. Item 5, do we have any petitions presented to us?
We have not received any in advance of the meeting.
Okay. In that case, we come to the first main item, and thank you, ladies. Perhaps if you would just introduce yourselves at the beginning, I'd be grateful, and a little explanation of what your role is. And then we come to item 6, the stammer services. So, Catherine, could you just tell us a little bit about yourself and what you do, first of all?
Yeah, absolutely. So my name is Catherine Woolley, and I'm a speech and language therapist who works in Oxfordshire. But today I'm here on behalf of Stammer, also known as the British Stammering Association. So we're a charity who's been around since 1978, and our role is to support individuals who stammer. That goes from childhood, so children, parents and families, all the way up to adults who stammer through employment, that can be across the kind of the age and spectrum. My role at Stammer is Children and Families Programme Coordinator. So my role is working exclusively with families, parents, children and young people. And so I'm here today to talk a little bit about the Berkshire Stammering Service and some kind of concerns that were raised to us by members of the community. But probably before I do that, I should probably allow my colleague here to present and to introduce yourself first.
Absolutely, thank you.
Hi everybody, I'm Rebecca Ganari. I'm from Berkshire Healthcare Foundation Trust, and I'm the lead for children, young people and family services for the west of the county currently. My background is also that I'm a speech and language therapist, although it's quite a number of years now since I've practiced clinically. And I've been asked to come along to really explain some of the rationale behind the recent service review and to provide some context for the colleagues.
Well, thank you, and you're both most welcome. Catherine, please present what you wish to say to us in your own time, 5-10 minutes, whatever you've prepared for us, we'd love to hear.
Yes, absolutely. So I'll try, I know I was supposed to stick to about 5 or 10 minutes or so I'll try not to take too long because I'm sure it'd be very easy for me to just keep going the whole afternoon, but I don't want to take up too much of your time. So I'm here today to talk about the Berkshire Stammering Service. And during this, I'm going to use the term stammering service. I know that fluency service is recommended in some of the reports, but here at Stammer, we generally want to use neutral language when we talk about stammering. And from our members, we've heard that fluency service can have the implication that you're always trying to get people to be fluent, the expectation of fluency. And we kind of want to say, actually, for a lot of people who stammer, fluency isn't necessarily the goal. The goal is to be a confident communicator. So I'm going to use stammering service just as a blanket term before we start, just to avoid any confusion. So I'm here because earlier in the year, some members of Berkshire Healthcare Trust raised concerns with us that the stammering service appeared to be reducing and staff members were leaving their roles and not being replaced. And there was talk of an imminent service review, but there wasn't any time frames for that at the time period. And staff were quite concerned about the level of pressure that was going to put on remaining staff members when they weren't necessarily being replaced by the trust. And staff members were trying to ask questions about that and learn more about what was happening, but were finding it challenging to know more about that service. So I wanted to come and just get involved to see if we could find out more about what was going on and make sure that the provision of support for children and young people in Berkshire would remain as it has been and as a successful service that it has been providing for many years. And as many of you have probably already seen, Berkshire helpfully presented us a report on Friday afternoon that gave a little bit more information about their service and where they stand so far. Some of the things I think might be helpful for us to learn a little bit more about today is the service review mentions 3 different ways in which the service could be shaped going forward. And I think it'd be really helpful for us perhaps for you a little bit later to learn a bit more about those 3 different options and how they might practically be able to be implemented into the kind of service structure going forward. Kind of one of my concerns, having looked through some of those different options, is particularly option 1, focuses really heavily on the use of the Michael Palin Centre. And now I know that's quite a specialist centre, so I'll talk a little bit more about that. The Michael Palin Centre is based in London. It's a tertiary service, so it's a very highly specialist service that provides assessments for children who stammer. Generally, those are second opinions or private assessments, unless you are based in the Borough of London, which it resides. They do not generally provide therapeutic service. So one of the options that was presented by Berkshire was looking at outsourcing that kind of specialist speech and language therapy service to the Michael Palin Centre and asking them to provide input for us or on behalf of Berkshire. And while I understand the concept behind that, it might be quite a challenge to ask all of our families in this local area to be going to London either for a one-off assessment or for regular intervention. Some of the other models have more of a balance that look more at support at a band 7 and a band 6 level. And I think that's the kind of area that we would be thinking about focusing our support towards. At present, Berkshire has had, until some of the recent changes in terms of provision, a band 7 and a band 6. So they've had band 7 clinical leads who are able to be highly specialist speech therapists in this area to provide support for the most complex cases, whereas they could then support those band 6 specialist therapists, train them up in different kinds of models of speech and language therapy in terms of Palin PCI, for example, or Lincoln, to support them through working through those cases with children who need more support, and also provide support then on the ground for more generalist speech and language therapists who might be able to provide universal or kind of lower levels of language therapy. So we'd like to learn a little bit more today, I think, about the different option models being presented and actually the benefits of those different models. One of the other things that was highlighted to us as a concern was while the service review was taking place, we were concerned about the fact that speech and language therapists were, when either retiring or choosing to leave, were not being replaced. And one of the therapists that we spoke to said that she'd expressly said in her exit interview that she would be happy to stay on for longer to support that service transformation and support any redesign that happens. But we know that she wasn't later approached either to stay on for longer or to be approached as bank staff to work during that interim process. And I think we'd quite like to know a little bit more about what's happening at present for those children and young people, because the service has been significantly reduced. It's now only, I think it's 1 day a week, over 2 different therapists, each working half a day a week to cover the entirety of both West Berkshire and East Berkshire. And I think that's quite a significant change in the service provision. And that was why it was raised to us as a concern, because that's quite a big change from having 2 band 7 therapists, and then I think it was 2 or 3 band 6s as well. 2 band 6.
And no, sorry, 3 across West and East, apologies.
That's all right. So it was quite a significant change in service provision over the past 6 to 12 months. And so we wanted to just be here to find out a little bit more about that quite big change in service provision and how that's having an impact on the children and young people here in Berkshire. And like I said, I could keep going all day, but I will start there just so we can learn a little bit more as well.
I think I see someone's already got their hand up. Can we break this up and question you perhaps a little?
Of course.
I'm going to claim chairman's privilege. Sorry, Councillor Lynn. Sorry.
Chairman, Vice Chairman, members, officers and guests, please excuse me, I have to attend another medical appointment.
Thank you, Councillor Beck.
Thank you.
Always welcome. Right. This lack of resource that you're talking about, do I take it that this is a national issue, a national problem? Or what do you feel can be done to assist in recruitment, more importantly, of course, retention of highly trained and motivated people.
Yeah, of course. It's a really good question. I think we know, as the whole country knows at the moment, that COVID has had a significant impact on services across the NHS, which does include speech and language therapy. And we know that there is an increase in the amount of children and young people who benefit from speech and language therapy support. I don't think that is to say that children who stammer shouldn't receive support because there are so many individuals that receive support. And one of the things that we know, looking across different healthcare trusts and across service provision more widely, many trusts have kind of specialist clinical pathways for children and young people who are identified as having a higher level of risk. So generally that includes dysphagia, so swallowing needs. Hearing impairment is quite a common one as well. And stammering is often seen as the third kind of core pathway that often requires higher specialist and more clinical support. That's not in terms of, so dysphagia, obviously the risk is you might swallow something and choke and die. For stammering, that risk is much more psychological. We know a lot about the psychological impact of stammering, particularly due to the high level of stigma that comes with stammering, due to, unfortunately, long and very pervasive attitudes in the media, on television, film, plays, almost anything you can find. Stammering is generally being laughed at, mocked at, a sign of weakness, nervousness, evil, often generally as well. So we know that there's a really big psychological risk that can come from people if they don't have a really holistic care pathway that includes not just speech management strategies, but also support for resilience, emotional well-being, communication skills, social communication skills. And those are the things that you're right, those specialist staff really benefit from having training in that a lot of generalist SLTs have training in, but don't have the time or capacity to be able to give. And I think you're right, in terms of retention and recruitment of staff, I think that's something that's really important. And I think it's something that's highlighted actually in the Berkshire report as something that can be a concern. And I think what's really important to acknowledge here is that Berkshire does already have staff at band 6 level who are interested in stammering, who do already work in this pathway and care about this pathway. They also, until very recently, had 2 band 7 staff who were also incredibly passionate about this area. And as I've already mentioned before, one of which was happy to stay on longer if they'd been able to do so, to be able to support a service transformation. And I think it's important when we look at service delivery and service pathways to think about how do you maintain staff morale? How do you encourage them to want to stay longer? And a lot of that is often due to looking at what kind of team are you creating? What kind of pathway do you want this to be? And how are you going to put clinical supervision, for example, additional training, and opportunities for you to be able to disseminate your skills to the rest of your team? And I think having space to be able to do those things is really important, because it's really easy for a stammering service to become 2 people who sit in a room and never speak to the rest of their teams, never know who else is in the department, never know who else is working on speech sounds or language or, dysphagia or anything else, and never meet the rest of the team, never be part of their team, and also never get the chance to share what they've learned and share their skills, and also then share their skills with other members and people who work in stammering. And actually, I think that's really important for staff retention and staff recruitment as well.
Well, thank you. Councillor Linden.
That's right.
Thank you, Chairman. Yeah, certainly what I'm known about was obviously the King's Speech.
Yes.
And also Michael Palin's 2 films.
Yeah.
Which had stammering in them. Either watch those films with a certain age to appreciate those. Yeah. Because there's also, I know the need for children, but there's also a need for adults. And certainly I'd like you to go further, and Rebecca as well. You know, if we don't provide a reasonable service, what is the indications? That's the first thing. And in terms of the well-being of those who suffer, I mean, we're talking varying degrees of stammer, obviously, and the implications what it has in their life chances or whatever in the future. So I'd like to cover a bit more on that and the need for that. It is quite a lot of people if we talk about East and West Berkshire. I mean, we're talking about a population of 945,000 plus thousands within the county. And in West Berkshire Council area, which is the unitary district, we are 55% of Berkshire, and quite a lot of it is rural.
Yeah.
And the chairman represents a rural ward. I'm in a suburban ward, but on the Reading boundary. So it is going to be a challenge providing that service and also working with reasonably rural as well as suburban. I mean, most of our population live in suburban areas. We also have deprivation as well. Surprisingly, it's not just in Reading and Slough. So there's all these factors. And if I look at the part-time sessions and having 3,228 people, children, and then of course there's adults on top. And that's in West, that's half of Berkshire, and then slightly less in the East. It's an alarming amount for a very valuable service with the difficulties I see within the NHS, which we all know about. So I know it's a long-standing, rambling question, but if you two could comment a bit more on that.
Yeah, of course. So I think I talked a little bit about the impact of stammering in my report, and I think it's always very difficult to quantify exactly what the impact of stammering is on an individual, because every individual is so unique, and we never know exactly what stammering is going to be like for that person and that person's experience. But I think, particularly having touched on that idea of stigma before, I think it can really make a big impact on someone's life. We know that there's negative stereotyping towards people who stammer. There's been a report, I think it was in 2011, which looked at behaviours towards people who stammer. And it found that if people negatively stereotype someone who stammers, stigmatise kind of in their thoughts, they reflect that in their behaviours. And we see that every day. So at my work, we look at employment tribunals where individuals who stammer have been told either not to explore certain careers, or recommended not to explore certain careers, or feel as though they've been passed up for promotions they should have deserved because someone has said, you need to have a good public speaking voice. To be a good public speaker, you need to be fluent. And the expectation that fluency is connected to goodness is something that's it's really difficult to shake. That you can be a good public speaker and stammer your way entirely through a sentence. It doesn't stop you being good at telling people your story and telling people your experiences. But we also know it has a big impact on education as well. Children who stammer report higher levels of teasing and bullying when they're at school. We know that they are more likely to be school excluders. So they might more likely, to be not attending school rather than being excluded from school. And we also know that there are high levels of anxiety and depression in individuals who haven't had support and received support. So we know that not supporting stammering at the earlier stages, so in kind of childhood and early adolescence, is more likely to lead to an impact in terms of quality of life at an older age, and therefore CAMS involvement potentially, or adult mental health support services in the future. So we know that the impact of stammering can be massive. That's not to say it's necessarily the case for every individual, and it's not to say that every individual will need to access all of that different support, but we know the potential implications for each of those young people if they don't receive specialist support. One of the things I think we also know is, as actually Berkshire said in their report as well, a lot of individuals, even speech and language therapists, don't feel confident knowing how to support children who stammer. And we see that in my service all the time. In fact, we actually had a call to our helpline just last week from a speech therapist in Berkshire asking us about how could they educate teachers and education staff in a child's school more effectively, which is something that actually their specialist staff should be able to help them with internally rather than having to come externally to us. And actually, I think we here at Stammer know that if staff don't feel confident knowing how to support children with stammer, speech therapists don't feel confident, you fall back onto what you know. So for speech therapists, 9 times out of 10, that's, I can help you be more fluent. And for some people, helping them be more fluent is the end goal, and it makes their life better. For a lot of people, it doesn't chase away that feeling of someone bullied me on the playground today, someone teased me. I don't feel confident the way I speak isn't good enough. You know, I'm worried about talking in situations every single day. You're not tackling the underlying anxiety, the underlying fear, and the underlying sense of self that is impacted by that stammer if you don't look at the whole person holistically. And I think that's the importance of a specialist service, is actually being able to say, I can go one step further. I've got the time, I've got the capacity, I've got the space to be able to give you what else you need. Because actually stammering is not as simple as being able to practice 6 different breathing exercises and you'll be cured. It doesn't work like that. And we know that. And actually there's so much more to it than that.
Chairman, can I just follow through? Obviously, I did also mention about adults.
Yes.
Paul here is in charge of adult social services. So
Yeah.
could you give a brief point on that as well?
Yeah, so today here we're kind of here to focus more on the NHS children's services.
Yes.
So I don't want to comment on what provision is like in Berkshire for adult services because I haven't done any research into the area, so I can't say. What I will say is, speaking from my own experience, so I work in Oxfordshire, which is quite nearby, and we have an adult service provision for adults who stammer. What I do know from my own experience is that we have adults who come back to the service at a much older age to say, actually, I was doing okay as a child and then I got a new job, or I got a girlfriend, or I got this, or something happened, I got divorced, and suddenly I'm in a crisis situation that I wasn't in before. And actually, we do see people come back to the service at an older age to receive additional support.
Thank you.
Right. I'm acutely aware, Rebecca, that we may be treading on your toes on what you want to say, for which I apologise. But Councillor Macro does have something very specific. So may I just get him to ask his question, and I'll come to you for your presentation and the points you wish to make.
So in the stammer report that we have, it says that the service provided with stammerers in this area was extremely good.
Yes.
One was mentioned somewhere.
Yes.
Where would we stand now, do you think, please?
It's a good question. So there was a criteria. It was done by the Action for Stammering Children organisation back in 2019. So they listed 1 to 4, 1 being, got to remember the exact details. It was 1 being extremely good, 2 is good, 3 is average, 4 is poor, or something along those lines. So when they did that survey back in 2019, as you say, we got rated as a 1, so extremely good. At present, based on what's currently still available, it's realistically gone down to probably a 2. It may have gone further. I'd have to go back and look at exactly the figures to determine the exact numbers. But the importance of that number was linked to the provision of that service and what stammering service you had available. And actually, if you've got half a day, effectively each member of staff trying to cover the entirety of this county, I think it'd be difficult to place that as a level 1 at present.
Okay, thank you.
Thank you. Rebecca, can we turn to you? Give you equal time, 5-10 minutes. Just tell us what this is about from your point of view, and we can ask, and we'll come to questions to both of you again if we find it. Rebecca.
Thanks very much. I haven't prepared a formal presentation, much like Catherine. I'll just sort of talk to the subject and on some of the points that have been raised, if that's okay. So, I mean, first of all, just hearing you speak, Catherine, I feel quite reassured because I think we are, whilst we presented 3 options in the options appraisal, we felt it was important to look at all possible scenarios. We really do value the specialist input from colleagues who have that additional training and experience within the service. So just as a starting point, I think it's important to say that whilst we felt it was timely to review the service, which actually has been working in a very similar way for well over 10 years, in fact, always receiving very, very positive feedback from service users. And it was really heartening to hear that, as part of the study that Stammer referenced, that Berkshire's service had been rated really highly. And I absolutely agree, as a speech and language therapist by background myself, with everything that Catherine said about the importance of early intervention, the importance of the right training and the appropriate levels of competence. And I absolutely think that there's real value from hearing feedback. Part of our review involved feedback from service users, from existing staff within the SIPIT service. SIPIT is children and young people's integrated therapies. And we're an integrated therapy service of speech and language therapists, occupational therapists and physios who work across Berkshire. And within that is the current stammering service, which we have called Fluency. My apologies, because I actually had thought that we'd been advised it should be called a Fluency service, so I'm learning as well. I'm not a specialist in stammering, as will be evident to all of you, I'm sure. But I did feel, just picking up on Councillor Linden's question around the scale of the numbers and the amount of children we're trying to support, I do think it is important to see that in the context of the wider service. Because of course we're commissioned by the integrated care boards, East and West, and by the local authorities across the county to provide services to children with and without education, health and care plans. I won't go into the intricacies of commissioning because it is very complicated. But essentially the current caseload for all children accessing speech and language therapy services from SIPIT is around 6,066 children in the county. The current caseload for the stammering service is between 40 and 60. I say between 40 and 60 because as part of the review, the specialists who are working with that caseload went through child by child, looking at the involvement that had been had in the past year and predicting whether that child is likely to require ongoing intervention or maybe approaching a point where they could have a conversation about discharging them. So, you know, I think in the context of 6,000 children, just to be reassured, we are talking about a very small number. That's not to say that that small number absolutely should not receive the right and timely input. But of course, as a public provider of services, we are responsible for ensuring that all of our resources are targeted to all children who have needs, including children with other specialist needs that Catherine's referenced. So children with dysphagia, so difficulties with swallowing, children who require alternative and augmentative communication, so communication aids, low-tech, high-tech aids, also children with developmental language disorders, which can have a really significant impact again on self-esteem and, you know, psychological and mental health impacts. So we do need to risk assess in the context of the wider population, because we are also risk assessing for all of those children with very wide-ranging needs. And I feel it is important also to acknowledge that, as you've said, Catherine, the demand for all of our services has grown very significantly since COVID. We've had around a 200% increase in the numbers of children being put forward for assessment around an education, health and care plan being issued. And for those of you that heard the BBC News today, I think only around 60% of those plans nationally are being issued in a timely way within the statutory timeframes. And that unfortunately is a combination of factors around educational psychologist availability and recruitment and around health providers' ability to recruit. As Catherine mentioned, there is a national crisis around recruitment. There's a shortage of allied health professionals nationally, not just in speech and language therapy, but in occupational therapy. So that is the climate in which we're working. In terms of our review of the Fluency service, I must admit on a personal level, I hadn't been aware that a colleague who was leaving the service had offered to stay on. So I'm afraid that's new information to me as an individual. But of course, it was important that we were unable to recruit people permanently into posts until we had clarity about how the service model would look moving forward. And we felt it was important to get that right and to have feedback from all relevant stakeholders before making an informed decision about how the service would look. So therefore, we did go out for some temporary staffing. We have an internal temporary staffing team who look through locum agencies, and we approached the specialist staff and generalist staff in the team who have an interest in stammering to see if anybody would be able to pick up additional hours. Unfortunately, the pressures on the wider service were such that there was nobody that felt able to do that for various reasons. So it is unfortunate, but just to reassure council members that it's certainly not the intention that the service stays as is. That is an unfortunate interim situation. We are risk managing all of the children, so every single child who is on the caseload currently and every child who is referred to that specialist pathway currently is being looked at by one of our specialist therapists to ensure that there are no red flags that may require us to seek immediate advice from the Michael Palin Centre or refer that child onward. I think some of the feedback that we acquired from staff internally absolutely backs up what you said, that many of them don't feel confident to meet the needs of children and young people who stammer. Many of them referenced that they felt really fortunate to have a specialist service internally that they could refer to. From our point of view as a leadership team reviewing the information that came back, it felt unfortunate that that was the way that they felt about working with children who stammer, because of course many of those therapists are in the school, they have existing relationships with the staff, with the families, with the children, and with the right support from specialist therapists within the team, who, as you said, Catherine, would ideally be kind of visible and embedded within the general teams so that that specialist knowledge can be shared. We feel that we could actually increase capacity for the generalist teams to be able to pick up and meet the needs of some of those young people who are at lower risk of a stammer that's pervasive and ongoing, and can manage some of those cases hopefully more swiftly rather than them being referred to an internal service. So I feel that the direction that our professional development lead who wrote this paper is going in terms of a recommendation is to step away from the idea of a separate stammering service and to move towards the idea of a stammering pathway within the main service, which would absolutely include some specially trained therapists who have that additional experience, knowledge and understanding, and who would have responsibility for their own continuing professional development. So attending networking groups, making sure that they're seeking the right training and approaching the managers about accessing that training. Berkshire Healthcare do have a really positive and proactive approach to training and development, and it's really important that all staff have the necessary skills to be able to safely deliver the requirements of their role. It's actually very much aligned with the way that we're looking to develop many aspects of the service. We can't ignore the fact that the demand has increased exponentially. I don't remember a time in my career where the demand so far outstripped capacity in every element of the service. So we have no option other than to think creatively, to think about how do we maximise capacity, how can we develop our services so that the children who are at highest risk, whether it be children who stammer, children with a developmental language disorder requiring early input, children who need a communication aid to be able to communicate, children with hearing impairments who have a very equivalent service model currently, where we have specialist trained hearing impairment therapists embedded within the main teams, and that then enables the therapists within the main teams to also work with those young people. We simply don't have capacity to be able to work with all children on an individualised basis. So the premise across all of our services is very much about, it's in line with the code of practice, it's in line with the SEND reforms, it's about empowering the people who are closest to the children, who are with the children most of the time, to better understand their needs, to better identify their needs, and to understand strategies that can be embedded throughout the day. Now, I absolutely recognise that there are a very small number of children for whom that isn't enough. And it's those children that we would be looking to signpost towards all of our specialist pathways. So we're in the process of developing a specialist pathway for developmental language disorder, and refining the hearing impairment pathway. And as you know, we're looking at the stammering pathway. So I think hopefully that gives a little bit of context. I apologise if that felt a little bit rambling, but I prefer to just speak off the cuff rather than talking to slides.
So do I. Thank you. Councillor Moore, you have a question.
Thank you. I'm not quite sure to whom the question is.
Launch the question and see who answers.
See who answers. And it's a pretty vague question in a way. I'm just interested in terms of the stammering service, what outcomes you're looking for, and the sort of corollary that goes with that is typically, and I'm sure it isn't typical, how long are you engaged with individual patients? That's
yes, I mean, I can't speak in a lot of detail about the amount of time that we're engaged with individual clients, and of course it is very individual to that person. Yeah. So it's really hard to say kind of an average length of stay, if you like, within the specialist pathway. As broadly as a SIPIT service, so the speech and language therapy service across all specialisms, we work in a very impact-based way. Rather than looking at the underlying condition or the diagnosis, we look at, well, what impact is that having for the individual. What effect is that having on their day-to-day functioning and on their ability to access the curriculum, to socialise, to go to job interviews, whatever that may be. And so my expectation would be that because we're looking at the impact of their needs, it's unlikely that their stammer will ever go away. They are learning strategies to cope, and there are times when it will be more difficult for them. And Catherine said, sometimes people may come back to the service when they have a job interview or they get a new girlfriend or whatever that may be. So my expectation would be that young people would come in and out of the service depending on what they needed at that time. I don't think it's helpful for any of our clients to remain on caseloads indefinitely, because there's a suggestion there that we're actively involved in some way and that we hold a duty of care and are working with that individual to achieve a desired outcome. So we would only expect to be having children and young people on our caseload if we're actively involved in supporting them with something. And I think our recent review had shown that there were a number of people who had been on the caseload but hadn't been seen for about a year. And if that's the case and nobody has contacted us to express concern and the young person themselves hasn't reached out, that would suggest to me, although I can't assume, but it would seem to suggest that there's no immediate need right now. That's not to say that young person won't then approach our services in the future and require some support around a specific life change or transition that they're experiencing. So I'm sorry, that's a really nebulous answer.
That's some interesting. It's quite a good idea.
Catherine, do you want to add briefly?
Yeah, I think one of the things I think I wanted to acknowledge is I think a little bit in the way that you were just saying about how you don't want children to stay on a caseload and have long gaps between being seen. I think one of the things that I personally have always found is quite different with stammering compared to perhaps some of the other speech and language difficulties or differences is sometimes the intensity of support you might require. So it might well be that an individual doesn't need support from speech and language therapy for several months, several years, but that period in which they do require support might be a period of potentially more acute crisis, where actually something is going really wrong, or they need perhaps a more significant period of input. So for example, the Lincoln therapy approach, to do it at its gold standard, it should be being done weekly. For quite a significant period of time, potentially until a child reaches a certain point. And actually, to be able to provide weekly intervention is something that a lot of generalist therapists often don't have capacity for because they have so many other children on their caseload. So I think often the specialist services, and particularly speech and language therapy or stammering, often they may not necessarily need to be on a caseload for a long period of time, but that time they do need to be there, they really need to be there. They need to be being seen with a regular amount of input and intervention, because actually otherwise you're not going to be able to make a change.
That makes sense. Thank you. And Councillor Linden.
Thank you, Chairman. Yes, so I've got 2 questions, and I'd like to thank Catherine and Rebecca so far. Going on how do you work with early years providers in schools? That's part of my first question. We know the SENs, because obviously discuss it. I do the home school transport appeals, and others do here as well, including Councillor Bridgman and myself. And how's that work, not only within our state schools, but also academies and also the private schools as well? How does that implicate that as well? So that's my first question. My second question is on page 23 of the report, which is the options.
Yes.
So I don't know, Rebecca, if you could outline your preferences, that might be useful.
Yes.
And why, and if Catherine wants to input on that as well. So those are my 2 questions.
Okay. I'm happy to talk about how we work with schools, if that's helpful. If it's
Do you want to start?
Yeah. So in terms of how we work with schools in general, every school has a named speech and language therapist. So historically, it used to be the case that there was a therapist who was there for what was the CCG funded part of the service, and another therapist would go in to deliver to children who have speech and language therapy in their EHCP in Section F. And then there were other pockets of funding that came in through various means in Reading and Slough and so on. We've really worked hard with schools to move away from that, to have one named therapist, regardless of who's funding it, whether the children have a plan or not, to have a really joined up, coherent service. So that's the first thing to say, and the same applies to early years settings. So every setting will have a named point of contact for speech and language therapy. In terms of the fluency service, where the risk can be safely managed by the therapist in school having advice and support from the specialist service, so those which there's an agreement that the child is at low risk of the SAMR becoming pervasive or persistent, then that would happen through the school, through the parents, working directly with the young person. But as Catherine has said, there are some young people that need a higher level of intervention, and those young people haven't been and wouldn't ever be picked up by the generalist service for the reasons Catherine's given. Because just to give a bit of context, I think with the stammering service as it stands, if we were fully staffed, so without any vacancy, then the average caseload per whole-time equivalent is around 40. In the mainstream caseload in mainstream schools, the average caseload is between 200 and 400, depending on how many schools are being held. So it's huge in terms of the number of children whose needs are being met. And for that reason, you're absolutely right, Catherine, it isn't practical for a generalist therapist to deliver that high level intervention. What is practical, though, is for that generalist therapist in the school where there's a child who's at lower risk, and there are some strategies that can be discussed with the specialist team and implemented within the school setting and with the family, that can absolutely be supported by the generalist therapist.
So going back to my point about academies, private schools and also homeschool, got about, could you give us some info on that?
So for children who don't have an education, health and care plan, they fall under the ICB funded, so the health funded part of our service, and that's based on where their GP is. So we would go into whichever school whichever school they're attending, whether that be a private school or an academy, or they might be invited to a clinic during the school holidays. The team do their utmost to see children in school because obviously that's their educational environment and that's where you can affect the greatest change, whatever their need may be. But we often invite children to clinics just from a practical level. It's not always possible. Some of the independent schools are geographically quite far out. For children who have an education, health and care plan, the issuing local authority fund whatever input is in section F. So if that child has an identified need specifically relating to stammering and a recommendation has been made and then known to the specialist service, that high level of input will be defined in section F of the plan. And we as the local provider would be required to deliver that. I'm not aware of any children currently that have a high level of input for stammering in section F of their plan. But if it did happen, then we are the commission provider, so that would be delivered. And we would look on a case-by-case basis to make sure that the person with the appropriate skills delivered that input. So that may well be one that the specialist therapist would be asked to pick up and work with.
So finally, my second question on the options.
Yes, so in terms of the three options, as I mentioned at the start, we felt compelled to present all three options. I would like to very clearly state that we don't have an intention to close down a specialist service or pathway. We just wanted to refine how that pathway looks to maximise capacity really, and to grow the skills of the generalist team to create more capacity. So our preference is either option 2 or option 3. In terms of, just thinking from a cost effective point of view and from making best use of the resources available to us. At the moment, I think we are sort of leaning in favour of the option which is band 6 therapists, and then also making some use of assistants in schools to deliver some of the intervention for the lower risk children, not for those children requiring specialist programmes such as Wickham. However, we do still have a focus group to run with service users. We're looking to do one with parents and one with young people in January. So it's unfortunate we weren't able to coordinate that prior to this meeting. That will inform our final decision. There are very many pros and cons of both, and I absolutely hear what Catherine's saying, that having a band 7 advanced therapist in the service is a real benefit to the other clinicians. It's not something we have for all specialisms, so we don't have a band 7 lead for developmental language disorder, for example, but there are a team of band 6s who all have access to specialist training. So it will be either option 2 or option 3. We are absolutely looking to have a specialist pathway, which will be very similar to our other specialist pathways, to make sure we're managing the risk appropriately.
So you'll let Vicky know?
Yes, of course,
Okay.
yes.
Thanks, Sean.
Thank you. Councillor Macro.
Thank you, Mr.
Would I be able to just make a quick comment? Sorry.
Yeah, but please do. Yeah.
I just wanted to kind of give my 2 pennies worth, if it's all right, about the differences between the option 2 and option 3. If that's all right.
Yes.
I completely acknowledge that both pathways have definite advantages to them in the sense of being able to train the wider workforce. And I think that's really helpful to enable generalist therapists to feel confident delivering a universal level of intervention. One of the things I would comment about option 3, I think there's always a danger of relying on speech and language therapy assistants to deliver the bulk of the work that we do. They are great. I love speech therapy assistants. We should have more of them. However, they haven't gone to university to do a speech and language therapy degree. They are qualified therapists. The training that they have and the abilities that they have are all determined by the level of training that they have themselves been provided with by speech and language therapists. And actually, I think to put the emphasis of care and support on them is always, it's a big burden to ask. And I think the real benefit of having a band 7, and I suspect, and although I haven't asked you in advance of this question, I suspect you'll find the kind of highly specialist pathways like dysphagia, AAC, and hearing impairment will have band 7s for a reason. And that reason is that they are very specific clinical pathways, very specific evidence bases that really determine the work that we do. And I think if stammering falls within one of those core clinical pathways, it should have a band 7, much as those other pathways do as well.
Before I go to Councillor Macro, this is fascinating to me. This is new to me as well. Rebecca, you're picking up a slightly different tone here from Catherine. I trust that you do talk to each other well and will continue to do so in determining which option is likely to go forward. Could that be reasonable?
Absolutely. And actually, Catherine and I hadn't had a conversation in advance of this meeting, but it will be extremely helpful to maintain a dialogue as we go forward with the focus groups. Obviously, if there are significant concerns around assistants delivering input, and I would like to reassure people it wasn't the intention that they deliver the bulk of the input, but that they would support delivery around some of that universal training, for example, for school staff, or universal reinforcement of the strategies being implemented. So I do feel there is a place for using staff who aren't qualified, and you're right, it is around making sure that our specialist clinical staff have trained the assistants to the appropriate level. We do have assistants in the service who've been with us for 20 years who are extraordinarily skilled and flexible at adapting therapy programmes and delivering training. One thing I didn't mention around increasing capacity as well, in terms of a principle of the offer that we're looking to build, is obviously since COVID, many services have gone online. And I know that colleagues within our stammering service fed back that many of the young people really liked that model. And for some of the teenagers in particular, they found it really accessible. And it meant that they didn't have to travel, they didn't have to miss as much school. So there are lots of real pros for that. But as a service more widely, we're really investing in digital developments and in having pre-recorded training packages, in delivering online training to schools and maximising that. And as part of whichever of the pathways we go forward with, we would look to have a rolling programme of training for all staff as well, which isn't something we've had to date. So actually having an annual refresher, which is mandatory for all staff around stammering and around some of the other specialisms we've mentioned. So I feel it will be a real strengthening of the offer.
Thank you. Councillor Macro.
Thank you. Got two questions really. One is, given that the service was very highly rated, I wondered what the reason was for doing the review. And secondly, I noticed that got a very poor response to the consultation exercise. Yeah. And I wondered if you'd done anything to find out why that response was so poor.
Well, it's interesting you mention that, because actually we have got speech and language therapy students making phone calls to parents as we speak, just to try and understand why there wasn't more positive engagement. We have found across the board that just of late, since COVID, when we've sent out any consultations or questionnaires, the response rate is unfortunately lower than was often the case pre-COVID. We don't really know why. I can't explain it. It is that way currently. I'm sorry, I can't remember the other part of the question. I apologise.
It was the reason.
The rationale for the review, thank you, yes. I think essentially it came down to feeling a responsibility for spending of public money, and recognising the huge increase in terms of demand versus capacity on the service more widely, and acknowledging that we can't provide an exceptional service for a very small number of children if actually we're seeing that there are caseloads which are just unmanageable in the main part of the service, where children's needs aren't being met in a timely way. And is there a way of looking at it differently so that we can still safely meet need, but deliver the service in a slightly different way or with a slightly different skill mix? So I think it was the combination of those wider service pressures alongside the fact that people were no longer in those posts. So it presented an opportunity to look at whether we maybe configured the staffing differently within that service.
Thank you.
Councillor Moore, do you wish to come back briefly?
Yeah, just to sort of follow on that, you gave us some figures about a 200% increase since COVID and such like. This was the wider picture, I think.
Yes,
wasn't it?
yeah.
I mean, which begs the question why. I mean, there was a lot of stuff, wasn't there, in COVID where people were, expecting things that were going to come out of it. Is that what you think you're seeing now? Do we know why that is?
I think the increase in demand for speech and language therapy services more broadly, a lot of the demand is in the early years, where of course children were born or were toddlers during the COVID pandemic, and so they weren't being socialised in the same way. They were in their home just with a parent. They weren't out and about meeting other children. So they didn't have the same opportunities to interact and to develop their language and communication skills. Alongside that, we're also seeing a large cohort of children who are on what's now known as an EBSA pathway, so emotionally based school avoiders, who following the pandemic, maybe they'd already had some form of anxiety or sensory need in school and were already finding it a challenging environment. Following the pandemic, where they were being homeschooled, then returning to that busy school environment just felt overwhelming for them. And so we're having to adapt our services to that, to go and visit some children in their homes because they're not in school, but they do have an EHCP. So I have to be honest, I don't think it's entirely to do with COVID, because we were seeing, if I look at some of the increase around the requests for education, health and care plan assessments, so we contribute from a health point of view to building up a picture of a child's needs to determine whether they have a plan. We were starting to see that growth from 2016. So it's been a steady increase through COVID, which has slightly accelerated, but we were on that trajectory anyway.
I fear that more will come out of the after effects of COVID, but I'm glad and reassured that you're on the case on that. Members, I see no more hands. We're asked to consider the report. I found the whole way in which you have expressed yourselves to us absolutely fascinating. And what delights me most, of course, is that you are talking very clearly to each other now, and probably, hopefully, will do into the future. So members, how do you wish to consider this report, and to what conclusion do you wish to reach? Or should we wait until you explore all these options in front of us, perhaps then liaising with Vicky to see the way forward as to how we can have any more input? I'm in your hands. What do you suggest? Councillor Linden.
Yes, Chairman, I think we should wait until the outcome of the report, whether it's us or the new Health and Scrutiny Committee, because we've got elections in there. I think, there's no point in rushing this, and this has been exceedingly useful indeed. It's opened us to a lot of knowledge up here, and also to Councillor Bridgman, who's the Chairman of the Health and Wellbeing Board. So I think, we can wait, Chairman. That's what I would suggest.
You've been in agreement?
Yeah, I think that sounds right to do. It'd be nice to have a report back once the decisions, the options is chosen and such like.
And the input from the focus groups.
Absolutely, yes. Ladies, it's been fascinating, and I personally have learned a huge amount in what is to you very much a very passionate topic, and I'm grateful to you for bringing that passion to us. Keep up the good work. Thank you.
Thank you.
You're very welcome to stay, or you're very welcome also to dive back to Oxfordshire if you so wish.
I think I might, otherwise I may get stuck here forever in the traffic. So.
Well, yes, it probably is a good time to go now. So thank you on behalf of everybody.
Thank you for having us.
Thank you.
We look forward to speaking to you again soon.
Absolutely.
Thank you.
We'll have a short pause whilst we'll get Gordon, we'll bring up the people from dentistry in. If you would, please.
Should be in the meeting notes to start the capture.
Okay.
Excuse me.
Thank you. Bye-bye.
Bye.
Right. Looking at the screen, may I welcome Hugh O'Keefe, our Senior Commissioning Manager for Dental NHS England. Welcome. Can you hear us?
Yes, I can. Thank you. Yeah.
Brilliant. David Chapman, I see, who is the System Clinical Lead for Pharmacy, Optometry and Dental Services, if I've got that correct. Can you hear us?
Yes, I can hear you. Yes, and you've got that correct as well.
Good. Thank you very much, gentlemen. And Nilesh Patel, the Chair of the Thames Valley Local Dental Network. Welcome. Can you hear us?
Yes, thank you. Yeah.
Good. Excellent. Right, if I may, could I ask Mr. O'Keefe, could you please give us a report on NHS dentistry? The floor is yours.
Thank you. You've got a paper just describing the commissioning arrangements we have for dental services in your patch. Hopefully it provides a clear understanding for you about how the system works and the range of services that we commission. It's not just primary care, it's hospital services, other community services as well. And there's information in there as well about how patients access services, treatment bans, the patient charge arrangements that there are for those services. So just a bit of background there. And you've also got information about numbers of practices in West Berkshire, the referral services, the levels of investment into those services in your patch. So hopefully that gives you a reasonable background about how things work. We can certainly pick up any questions on the detail of that if that would be helpful. And then the paper focuses on the impact of the coronavirus pandemic, which hit dental services pretty hard in terms of the safety requirements around treatment of patients. And essentially, dental services ran at somewhere below 100% capacity for a period of about 2 years. They've only really got back to full capacity since July. So what we've seen in that time is a significant fall in the number of patients accessing dental care. So patients aren't registered with dental practices as they are with GPs. And we tend to then assess access in terms of the numbers of patients attending over a 2-year period. And you've got a graph in there which tracks the impact of the pandemic in terms of the numbers of people accessing dental services in the BOB area over that period of time. And what you can see in that as well is that dental access is improving. It has started to recover since the start of this year. We're still some way below where we were pre-pandemic. Normally, around about 50% of the population would attend a dentist on what's known as a continuing care basis. They're regular attenders at an NHS dentist. Normally about 52%, they're probably in this area slightly above what you'd expect to see with that national average, but it fell very sharply during the pandemic. And in terms of that recovery that we're showing you, a lot of that will relate to people who've regularly attended a dentist in the past, and the dentist is now calling them back in. So they've got big backlogs to get through in terms of the impact of the pandemic. But for those patients who've been in the system previously, things are improving, and they are getting back into the system or being booked in the near future. It's proving much more challenging for people who have not attended regularly. So there's a percentage of the population just go privately anyway, don't use NHS services, and there's a percentage who only tend to go when they have a problem, or there are people who may struggle, but they haven't accessed a local dentist, they move around. This might be, say, families of military personnel, they move around and are finding it difficult to get it back into the system. So the paper talks about the sort of work that's being done to try to address that through things like the additional access sessions that are provided in certain practices, the small number of those practices that support patients who can't find access to a local practice and can attend there. And also we've invested into restoration and reset funding, it's called, which is into referral services in the community and in hospital to try and bring down the number of long waiters. And that's proving to be fairly successful in terms of addressing that, particularly in the hospitals. You're probably hearing quite regularly about them attacking the tail in terms of the number of the long waiters, the 2-year waits. They're down to no one's waiting more than 2 years for hospital services now. I think it's fair to say that the recovery from this is still at an early stage. There are significant issues in terms of, because people have had a sort of gap in terms of their treatment needs are higher. As they come back into the system, they need to spend longer in treatment. That impacts the pace then at which the dental practices are able to get through that backlog. And also the workforce issues that are beginning to emerge. And again, it's no different to probably what you're hearing about a lot of NHS services, lots of issues around morale, recruitment and retention challenges for NHS dentists. Across the southeast, we have lost a number of practices who've decided to hand back their contracts and go private. That's not happened in the West Berkshire area yet, but it's an ever-present risk for us in terms of whether practices feel they wish to maintain their commitment to the NHS, and part of that is driven by whether they can recruit the dentists to come in and work on the NHS and therefore be able to deliver their contracts. So in addition to the sort of things we've talked about, there's work going on nationally now in recognition of these sorts of issues. Contract changes are being made this year to try and increase the capacity within the system. We've been told this is a sort of first phase of making these changes. And then we're looking at some work locally as to whether we can flex these contracts we've got to try to set aside more capacity to support those patients who are struggling to access the system. So we're working on a proposal that's going to go to a meeting next week and again seek expressions of interest from practices to try to adjust their contracts and try and scale up that capacity to support people who've found it difficult to get into the system. So in summary, the overall picture has been very difficult over the last couple of years with the pandemic. It is slowly improving. There are certain patient groups where it's really still very difficult, and we are working on a number of schemes to try to address that. Thank you.
Well, thank you. A couple of very minor breakdowns in this system, but we got, I think, virtually everything there, which is good. No, thank you. I mean, Mr. Patel, Mr. Chapman, is there anything you wish to add to that at this point, or are you here to answer questions? I'm in your hands.
I mean, it may be better to answer your questions. I assume you've all read the papers. The only thing to mention is that there's a new way of commissioning dentistry. So it was done from NHS England directly. Yes. With the formation of the ICBs, that's now we're in Bob, part of an early phase, the first year phase of having the services delegated, that's across pharmacy, optometry and dentistry, to the ICB. But we're working in conjunction with 6 other ICBs in the Southeast region. And still a lot of the for example, contract design and negotiations is held by NHS England. And then by 23-24, then all of these 3 services, the pod services, will be delegated to all the ICBs. So we are a front runner in that. And so we've been working in conjunction with NHS England through some of these problems, which in itself has caused sort of areas of learning across the whole system, I think, which will be helpful elsewhere. But it has led to slight difficulties, I guess, in terms of how quickly things can be changed at the moment, and hopefully will be in the future. And one thing in particular that the ICB is very interested is addressing health inequalities, and I think dentistry does display that. The details of that is sometimes lost with the data that we've got so far. But one of the I think what at the moment, some of the most deprived areas are probably suffering most in terms of access to dentists, particularly in this recovery phase. And that's something we would like to address. And some of the schemes that we're putting forward may address some aspects of that, but it's a work in progress.
Mr. Patel, do you wish to add anything at this point?
No, I think Hugh and David have covered most of it, but I'm happy to answer any questions other than clinical myself.
I do appreciate the difficult time we've all been through, and I'm glad we're on a road to recovery to a great extent. There are a lot of anecdotal stories, of course, which we've all heard of and read, but I specifically know through grandchildren some difficulties, or let's say extended waiting times with in particular orthodontic work. Is this an area of particular concern, or is this being addressed as part of the overall picture that you've just painted?
It is that there is a backlog that has built up for orthodontics. So clinically, I think it's relatively low risk. There's a sort of window, ideally of about 3 years, within which to commence treatment. And what the orthodontists do is they sort of scan their lists to just make sure people are coming through to the right age for that treatment. I think one of the things we do want to look at in a bit more detail is variation in numbers waiting at orthodontic practices. There seems to be quite a span of numbers waiting at each practice, and we think there's something that could be done about that in terms of potentially more joint work in between the practices in terms of managing those lists, because some practices waiting lists are much shorter than others.
Okay, right. Anyway, all three other members have their hands raised, so let's see what questions they're about to ask you. So Councillor Macro first.
Thank you, Mr. Chairman. Mentioned in the report that also just now that the national contract has changed, took effect in November, I think, as I said. I wonder what those changes are.
They're about allowing the dentist to perform more activity under their contract. A requirement for dentists to provide more information about on the nhs.uk website. I don't know if people know that website, Find a Dentist, about making sure that information is up to date. It gives us more contractual powers to look to, in effect, redistribute the resource that's allocated to the practices in relation to the level of activity they deliver. That's either sort of through a mid-year process or at the end of 23-24. There's going to be sort of new powers brought in for the commissioner to address that, and a sort of push on the dentists sort of clearly following NICE guidance in terms of recall intervals. So it's trying to make sure that they're clinically appropriate. And the other aspect, which I think is the last one I can capture, is to do with one of the treatment bans that the dentists provide for patients. There's a sort of there's an increase in payment can be made for more complex treatments. So one of the things that dentists have been saying is that the risk for them in terms of the way the contract works is that if they get patients with very high needs, but they have a set sort of amount of money they get paid for those, there's a sort of disincentive built into that contract to treat high needs patients. So the change that's being made now is to try to address that in terms of increase that payment.
Thank you. Councillor Linden.
Thank you, Chairman. Yeah, we've obviously looked at dentistry for this health scrutiny when I was chairman, and then we had a break on having health scrutiny, and again when we started health scrutiny up again. So obviously, I just a general point on hearing the answers. Obviously, there is some digital gaps, especially for non-users and those who don't use the service, maybe due to deprivation, and also poor contact. I know we're improving broadband throughout the district, but obviously Hugh, as you was talking about the private sector as well, and that's a major part. And I use private dentistry, I use public health, the GP services and natural health, the rest of my health requirements. But the private sector is important. And speaking to my dentist, she told me that she only takes in children. So I wanted to also ask, that's a general comment on effect, but also for Nilesh, do you represent both NHS and private? If you could answer that as well, that'd be very useful, and your input on that, because I think we need to be holistically, because of the percentage using both services, and also the lack of people using dentistry. I know it's very difficult for people to access, certainly adults, NHS dentistry. I know one of my fellow councillors had grave problems in trying to deal with their dental needs. So it is a problem. So it's a roundabout question, but I just thought I'd ask it anyway. Yes. Yes,
gentlemen, did you get the drift? If you could do your best.
Yeah. Okay. So my position is an NHS position, and so the main concern of what we do relates to NHS provision. But as with most practices, there's a mixture of NHS and private in all practices. So we are aware of the mixture. I myself do a mixture, but predominantly the predominant role of what we do is for NHS dentistry. But obviously, private provision is a helpful contribution to general dental health of the area, because obviously when people see a private dentist, it takes away some of the strain from what we offer in NHS. I'm not sure if that answered the question.
Well, that answers my question to you, but generally, Hugh, could you just update on that?
Could you just sort of summarise the question again?
Could you succinctly put your question, Tony?
Yes. So there was two questions. One is the digital divide,
right?
Okay?
Yes.
And the second one is the that we're not covering, because there are people who do private, so that's covered, as mentioned. But there are an awful lot of people who are not accessing health. I know you covered it initially.
The flexing we've talked about with the contracts is picking up on David's point he was making earlier, really, about the health inequalities agenda. So the way the dental contracts work at the moment is they're very much target driven, and so sort of respond to patients sort of coming in to see them, and there's a sort of always a challenge for access into those services. So we're trying to flip it round a bit in terms of setting aside capacity within the contracts for access to work more proactively in terms of trying to bring people into the system. So that's particularly, say, younger children. So we've run some pilots pre-pandemic about things like Starting Well in Slough, which was really about practices promoting themselves in local communities and working with those communities to encourage people, children at a very early age, into those dental practices. Now that had some additional funding that was made available through a national programme. What we're trying to do that is look at the extent to which we could do that within the contracts that we have, and then still maintain the access levels that we've achieved before. That's trying to look at how we manage the whole resource. But there's certain patient groups, particularly younger children from more deprived backgrounds, where we see them really overrepresented in the hospital statistics for extractions. And then there's older patients as well. So for many of them, making sure they're able to access services, whether at home or in care homes. So this is part of what we're trying to do with this flexing of the contracts. We're at an early stage yet in terms of trying to develop it as an idea, just trying to help people get into the system. But we are now looking through our local dental network, whether we can look beyond that to see if we can more proactively support people actually get into the system where their oral health needs are greater.
Do you have an actual target time for achieving that, or a hopeful time for achieving that?
Next week we're trying to get approval for the proposal, and then from there, so we're not there yet in terms of having it signed off. But it's worth saying this is an idea that's been worked up between us, the local dental network, and the integrated care board. So we think there's a good head of steam behind it as an idea, and the key really for us is going to be, can we get the buy-in from the practices to do it, because they're independent contractors. We've got to make them do it, but it's trying to sort of create some sort of environment where they think there's maybe something in it for them to take part in this, recognizing the needs of their own patients, that some of them they're going to need more time in terms of their treatment, or spend more time with them in terms of working with them on their oral health, and this might help them do that.
Okay, thank you. Councillor Moore.
Thank you. I was intrigued with one of the statistics in the paper that we got to read was that the 52% of the population attended an NHS dentist, which I was quite encouraged by. Actually, I thought that was higher than I was expecting. But did I get from somebody that that people were not necessarily signed up with an NHS dentist in the same way that we expect to be signed up with a GP surgery?
Yeah.
Is that the case? And is there any intention to try to change that?
So I think that's a helpful point about the access issue, the 52%, and it's worth saying that represented a significant growth in the 10-year period before that, about 30% growth in numbers accessing NHS dentistry. People might remember in the sort of noughties, the National Dental Access Programme, which was sort of led by the government, really designed to improve access, which had fallen away very badly since the 1990s. So it took us back to the sort of 1990s level. In terms of the relationship patients have with dentists, yes, we're not registered. Dentists are only responsible for patients whilst they're in a course of treatment. But really, the way it works is if we go regularly, we're kind of seen as being on the dentist books. And it's a sort of akin to register. I'm NHS. I get called in regularly for checkups, and so if you're in that system, it does work very well for you. And pre-pandemic, I think we probably had arrangements that supported people who wanted to come in as they felt they needed to. I think that's got much more difficult since the pandemic to do that.
Right, thank you. And if I could just follow that up, so I'm intrigued because. Dentistry, if you like, has practiced, it seems to me, what medicine preaches, which is about prevention rather than treatment. And so I think back to my own experience. 6 months regular checkups, in the dentist and such like, in a way that if I'd been to the GP surgery in the last 5 years, I feel quite pleased about that I haven't been there. But I just wonder whether the balance is right, whether in fact we've got, the part of the capacity issue is, we're all getting our 6 months checkups, whether you're a private patient or NHS, and is that more than we need? Has any study looked at that?
This is part of. There is sort of guidance on that about recall intervals and who should come in at more regular intervals. It tends to be us older folks. We're known as the heavy metal generation who've had lots of fill-in. We were younger, so we have to go in quite regularly. But for people a little bit younger, don't have to go in as often. There's fluoride toothpaste, I understand, only became widely available in the early 1970s. So again, so for lots of people, if you predate that, your oral health is probably more at risk than those who've grown up with fluoride toothpaste. And and dentists are conscious of the recall intervals. They don't just call people back every 6 months, unless they need to. But there is a kind of built-in, again, within the contract that they have. There's a sort of built-in incentive to get those recalls through, and also patients, again, if we're all creatures of habit, if we've been having these 6 monthly recalls over the period of our lives, we tend to like to push for them, and probably we're all quite keen to prevent anything going wrong with our teeth because of various other fears we might have in respect of treatment. But there is guidance on it, and there are clinical markers about who should come in at various intervals.
Can I just intervene at that point? That actually prevention starts not going to the dentist in the first place, and that's making sure that children learn and patients learn how to look after their own teeth, how to brush, how to spit, not to rinse, simple things, and use fluoride toothpaste. And there is a whole range of sort of cheap toothpaste which have the right amount of fluoride in these hardened times, which patients could be directed towards, or people could be directed towards, which doesn't involve necessarily going to Colgate or whatever else, and does an adequate job. And I think councils, Hugh will correct me, but I think councils through their public health departments are responsible for that health promotion, and also responsible, although it's optional, I think, for doing a survey of dental hygiene in children, I believe. And some councils have opted in Bob, I believe, not to do that, which is slightly unfortunate. Is that correct, Hugh?
Yes, it is. Yes.
Oh, right. Okay. I empathise with the wonderful term, the heavy metal generation. I hadn't heard it called that before,
No.
but I'm obviously clearly part of that. And hasn't dentistry changed from the 50s and 60s to the 70s, 80s, or 80s, certainly, with fissure sealing and other preventative measures, which certainly my children benefited from. I think one of the prime points has just come out very recently. The last speaker, David, you said about health promotion, the dental hygiene, and this should be part of, I'm not abdicating parental responsibility, which should be key, but it should be also part of the school curriculum to ensure that proper dental hygiene, because I know for sure prevention is certainly better than cure, and the treatments of small fillings becoming big fillings, becoming root canals, becoming ultimately to crowns and implants. And I think I've got a good mixture of all of those, so I do understand fully. Gentlemen, is there anything else that you think we have missed, or any other points that you wish to make briefly now? I think everyone asks questions.
You've got a hand on it.
Am I aware?
Sarah Deason.
Hi.
It's been there for some time.
Has it? I do apologise. Oh, there's a, it's because I can't see the picture. Now I see. Sorry. Hello.
Hi. Sarah Deason, Health Watch West Berkshire.
Yes,
I just had a question about the comment in the report about and in the presentation about why people aren't registering, and I wondered if you've done any engagement locally to find that comes from local engagement with people, and also how you're going to advertise the fact that there are spaces at GP surgeries, because that's one of the top things we get across the 3 Berkshire West Health Watch is questions about where can I get a dentist.
Okay.
Well, again,
that's a very good point. Can you answer it?
Yes. So, and Sarah, it is worth saying that the nhs.uk site is where we tend to point people to, because that's one of those ones you put in your postcode and you can find your nearest dentist. But it is worth saying that it is difficult for anyone to, at this point, to find a practice that's open to new patients. we think a lot of that is related to, yes, they're catching up with the backlog and they're trying to deliver their contract targets for the year. So that's a key place to at least get information. One of the things we want to try to do with this flexing program we're talking about is have alongside it a sort of comms plan, which is sort of then saying about, well, if we find practices to take part in this scheme, making other agencies aware of the fact that they're doing it, making it known through NHS 111, and trying to promote access in those communities. The reasons patients don't attend on a regular basis is actually relatively well known. There's been quite a lot of research on that. So there is the issue about money, the patient charges apply, which will put people off and probably at this stage be more of an issue than in recent times. And there's also anxiety that patients have about going to the dentist. So we've got high street sedation services, and a lot of the people who go to those services are those who don't attend on a regular basis and need that sort of support to go to those services. One of the reasons we do try to encourage people to go early in life and to go regularly, because it starts to help with that fear. And I think these are the sorts of things we want to get out more into the public ether if we feel we can get the sort of system more open back up for people to access as new patients.
Right. As in all aspects of life, communication is key. Indeed. Right. Councillor Linden, briefly, do you have the last question you wish to ask?
No, we've got next steps and review on page 31, Chairman. Yeah. And I would suggest we follow that through. I don't know if any members wish to add to that, but also that we will need to revisit dentistry possibly in a year or two's time, and just keep that open, Chairman. That's what I would suggest.
I think that's very helpful, and I'm grateful to you for saying that. I mean, Councillor Moore, do you wish to?
Yeah, I was just thinking, just following on that theme, I'm intrigued by the comment just there about the responsibility of the Director of Public Health for dental health and hygiene and keeping that in front. And I honestly don't know whether our Director of Public Health does anything like that. So that might be a bit of research for us for next time or something like that.
Oh, I can ask Vicky if she could follow that one up for us. Perhaps, as you say, Councillor Linden, if we could revisit, in that there is a lot of work ongoing to engage with patients, which clearly we obviously support. I'd be most grateful if we could revisit this at a relevant time when that work is progressing. Would that be a reasonable thing to ask?
Sure.
All right. Sorry, Mr. Patel.
Yeah, thank you.
I'm sorry.
No, it's fine. I should probably highlight in regards to prevention agenda, everything that David and Hugh was absolutely correct. But the other part we do in dentistry is it's not just about cleaning your teeth and how often you do it. It's about the food you intake and your diet. And so that's a huge part in reducing the chances of getting cavities in the mouth. And that is what we can also play a bigger part in general health. Half the time in an examination appointment, we're talking to children or adults about how they can reduce the chance of getting decay. And that's not just about cleaning, it's about reducing the consumption of sugary snacks. There's links between things such as periodontal disease, that's gum disease, and diabetes, pregnant women and low birth weight, increasing the health of children, reducing the chances of them going to hospitals to go have GAs, making sure they don't have low birth weight so they can concentrate at school, because we have too many children nowadays who have toothache and who can't go to sleep and who can't concentrate at school. So it's a much bigger part than just teeth, and it's making sure that's highlighted.
Absolutely. Yeah, no, I couldn't agree more, and I understand fully. And thank you for making that point. Members, I think again, we've learned a lot, and I'm grateful. I think it would be the best plan to bring this back for further scrutiny. Keep up the good work, please. I know you will. Is there anything else? There's nothing else that you wish to mention. Gentlemen, Mayor, thank you very much indeed for your time. Thank you.
Thank you.
Thank you very much. Thank you.
We have, I'm slightly out of order on this. I'm going to say item 9 next, the Integrated Care Board update. And Sarah Webster is with us. I gather this is your first meeting as well as mine. I welcome you and thank you for your patience sitting through all the previous reports, which I hope you found interesting. Would you please give us a brief update on the Integrated Care Board activities and commissioning plans?
Yes, of course. Thank you very much, Chair. If it's helpful, I might just very quickly give an overview of the new landscape that we're working in and where I fit in with that, so you can help picture me and my roles. So we are all now part of an integrated care partnership across Berkshire West, Oxfordshire and Buckinghamshire. That partnership is made up of the 5 lead local authorities within that footprint, of which West Berkshire is one, and the NHS. And the NHS body that's now part of the partnership is called the Integrated Care Board. The Integrated Care Board used to be 3 separate clinical commissioning groups. We are now one. And my role is as the lead director for Berkshire West within the Integrated Care Board. So that's where I fit in. So for today's meeting, I wanted to be able to give an overview on the strategy and the broader picture that we've been working on as we've developed this as a partnership. But first, I thought it was important to highlight a couple of really relevant topics at the moment from an NHS and healthcare perspective, and then I'll talk about the broader strategy if I may. So in terms of a bit more of a general update, so you'll all be cognizant of the news around Strep A at the moment and the impact that is having on the relevant services and a level of anxiety that's being caused at the moment across the country. So that is translating into significant demand for urgent care services. So our out of hours services over the weekend saw about 5 times the usual level of demand. 111 services are seeing about 150% normal activity volumes, and all of our primary care colleagues are experiencing significant demand for urgent appointments in primary care. So we've been monitoring the situation very closely over the past few days, and yesterday we've contacted all of our primary care providers to see if any additional capacity is available with funding associated with that. So that was just yesterday. So we're working through that, but we want to make sure that we are able to meet the demand that's coming through at the moment. Whilst also offering what I'm hoping is a reassuring message at all possible opportunities to say that whilst Strep A is an illness that particularly young children are impacted by, it is only in very, very rare cases that it becomes a serious health issue. Generally, it's something that's very easily managed at home with the right antibiotics. The position on antibiotics, I know we've had some feedback that it's been challenging to access the right antibiotics at all of our pharmacies, and this is being managed by NHS England. And the messaging is that there is a suitable level of supply within the country. We just need to make sure it's in the right place and appropriately distributed. Either the amoxicillin, which is the main antibiotic, but also alternatives. And there's been a lot of information to GPs and pharmacies around how we can meet the prescribing demand. So that is being managed at the moment. So I hope that's a helpful update there. We've also got the impending industrial action that's coming this week. So at the moment, we are still anticipating a nursing strike on the 15th and the 20th of December. In terms of organisations that are affected, the Royal Berkshire Foundation Trust was one of those organisations that met the threshold for the strike. So we are working very closely with them to make sure that appropriate plans are in place to mitigate the impact of that. I wanted to provide reassurance that emergency care will still be provided, and they are pursuing various derogations in other areas as well, with mitigating plans in place where it is anticipated that services will be impacted. There's a significant alignment of administration resource to make sure that any impact on our population who are expecting appointments on those days can be contacted urgently in advance if their plans are going to be affected by this, and we'll just continue managing that as it progresses. But from speaking directly with the Chief Executive and Chief Medical Officer at the Royal Berkshire, they are confident that safety won't be compromised. That is obviously the most important consideration here. So another update. So at your last meeting, Belinda updated on the urgent care centre that was due to open, and that did open last week, slightly later than planned, but that was due to the need to put in appropriate arrangements for that. So that is an urgent care centre in the Broad Street Mall in Reading that is designed to take in about 50 on the day self-presentations, people who arrive and seeking urgent care, and 50 referrals in from the emergency department and from primary care colleagues. So we're hoping that a combination of this capacity plus the additional GP capacity that I've just mentioned that we've announced earlier this week will really help to meet some of the urgent care demand that we're expecting over the coming weeks as we get further into winter. The urgent care centre is an 18-month pilot that we're going to continue to review the model and make sure it's having the impact we want it to, and then we can consider the longer term arrangements from there. And then the other thing I wanted to mention, and I think I can see Paul in the room, and Councillor Bridgman might want to come in as well, is the recent announcement around the adult social care discharge funding. So the national £500 million allocation has thankfully been confirmed. For West Berkshire, that's £1.2 million coming into the West Berkshire system within a 3.4 million envelope for Berkshire West. We've had some really constructive conversations as a system on how this money is going to be used to support continuation of service provision, noting the high demand we're experiencing at the moment. And I know Councillor Bridgman has already had a chance to review and provide some approval on those plans, and we're just further discussing those this week before they're submitted at the end of the week. But again, a very pragmatic approach has been taken, and where services could be stood up sooner, we just want to get on with it. So really pleased to have that funding coming into the system, and we're hoping it will help to, again, support services through the winter. So I'll pause there in case there's any questions on those subject-specific updates, and then I'll just quickly touch on the broader strategy, if that's okay, Chair.
Oh, thank you very much indeed. Councillor Bridgman, you were invited to make comment, and I would also invite you to make comment, so please do.
Thank you, Chairman. Yes, on the subject of the discharge money, the reason I'm involved in this, I mean, clearly Councillor Stewart, as portfolio holder for adult social care, is very involved in this in terms of delivery, but the reason I'm involved is because the way in which the money lands is through the Better Care Fund. And the Health and Wellbeing Board has ownership, as you like, of the Better Care Fund. And if you look back at our meeting last week, last Thursday, the decision was taken to effectively give me sign-off of this particular tranche of money, because the timescale is so short, we can't have a complete meeting of the Health and Wellbeing Board to look at it again. So I've looked at the way in which we are delivering the just under 1.2 million of funding. Roughly 700,000 of that is coming down through the ICB process, and about 400,000 is coming direct to the council. But they both land in the same place effectively, and they're then lumped together. And most of that will be spent on domiciliary care, in order to discharge patients from hospital. I do have some other pointers on the general subject of Bob, the ICS, the ICP, but I'll let Sarah conclude her comments, and then maybe I come in just to tell you where we are, because of course, whilst Sarah is looking at things from an integrated care board and place-based partnership perspective, to some extent, I'm looking at it from the integrated care partnership piece, i.e. the 5 local authorities and the ICB working in tandem, in particular to deliver strategy. But I'll let Sarah conclude, and then maybe I'll come in at the end of that.
Now that's helpful. Thank you very much. Councillor Moore, you have a question? I
was just a quick follow-up, really, would just to say, to ask whether, if it's going for domiciliary care, are there the people there to be recruited to deliver it?
Well, Chairman, I mean, clearly you have Paul Coe in the room. Perhaps that's more a question for him than it is for me. All I'm saying is that that is in terms of that you've obviously got to tell the government how you're going to spend the money. Yeah. And therefore there are rows and rows and rows of budgetary to spend. But all I'm saying is that if you look at the budgetary spend, most of the money, the rows for most of the money is in relation to domiciliary care. But I'll let Paul.
Yeah, Paul, can you assist?
Yeah, of course. So yeah, there are roughly a dozen lines I think are itemised within our plan, and very helpful to have seen Reading Borough Council and Woking Borough Council's plans also earlier today. Pretty similar. Yeah, domiciliary care is a big chunk of the money, and actually we're currently in a pretty happy position in West Berkshire for the availability of care agencies. Other lines include care home beds, staff to undertake the assessments in hospital and outside of hospital. So there's multiple lines, but I think the chunky numbers are essentially about making sure that we can buy care so that when people are discharged, they can be discharged safely.
Absolutely.
The support they need.
Okay, that's helpful. Thank you. Councillor Macro.
Thank you. Yeah, I did wonder about the availability of domiciliary care as well. Sarah mentioned the strikes, nursing strikes, and informing patients of whether their procedures are going ahead or not. I did read today that this is somewhat compromised by the postal strike. And that some hospitals have got kind of banks of people phoning up patients to tell them whether to come in or not. Is that the situation locally?
So we are not relying solely on letters to make those communications, largely because they're also very short notice. So it's telephone calls to patients to give them updates.
And is that diversion of staff going to have any effect on other services?
No, it's a realignment as we have as the hospital does as needed when you've got these urgent circumstances. So it's absolutely appropriate for the admin teams to be spending a large portion of time, hopefully a very short period of time, doing this reallocation and administrative tasks associated with the strike.
Thank you. Thank you. Helpful. Councillor Linden.
Yes, so just on adding the point from Councillor Macro, obviously we can use digital contact for people and then follow them up if they don't contact for those who have a digital service, of course. But the other brief point I was going to raise was, of course, we've had one meeting, but we need a joint health scrutiny body of all 5 authorities will be meeting again shortly. And that will obviously have an impact in terms of health scrutiny on the integrated board. So I just thought I'd add that. I don't know if Sarah, you wish to comment on that. Thank you, Chairman.
Okay. Sarah, I mean, is there a comment you wish to make on that, or?
No, probably not. I think Councillor Linden's summarised the group meeting, and it'll be interesting to see how that plays into what I'll come on to talk about in terms of the broader piece.
Absolutely. And just a brief comment on the urgent care centre, which I think at least I saw publicity on it, and I wish it well. It may not be a huge benefit directly to us living in more rural parts of rural West Berkshire.
Some places are not far away.
but some are nearer to it than others, absolutely. Yeah. But I wish it well. There's more you wish to say to us, I gather.
Chairman, before Sarah speaks again, if I may just comment on the urgent care centre. Clearly, now I speak as a governor of Royal Berks, and there is immense pressure, or has been immense pressure, on the emergency department of the Royal Berks. And the hope, very much the hope, is that recreating, and we've had it before, recreating the urgent care centre in the Butt Centre in Reading will take some of that pressure off ED. Let's all keep our fingers and toes crossed, because that's really what we need to see happen, because the pressure on ED in the Royal Berks is immense.
Absolutely, I fully understand and agree, and I think I was alluding to the fact that it's a valuable resource, and although I wouldn't wish it to be well used in one sense, I hope it is in another. Sarah, back to you.
Thank you. So we've spoken about the integrated care partnership across the broader geographical footprint, and you'll have seen the information in the papers around the development of the strategy. So as a partnership, we want to be very clear on our strategic direction and how we're all going to work together as a partnership of organisations to make a difference for the people in our populations. And we don't expect everybody to be able to articulate that we've got an integrated care partnership and this is how all of the health and care commissioning arrangements work. But wouldn't it be nice if in a few years' time, people say, I don't know what happened, but something must have changed because things feel a bit more seamless and things feel a bit more joined up. So that's the crux of what we're trying to achieve. I will say that the strategy that's been developed is a developing document. At the moment, we've got a draft that we are about to go out to wider consultation on. It's very much been co-produced, so this isn't a health document or a local authority document. It's a partnership strategy document that has been built up from health and wellbeing strategies. And I think that's really important to highlight that point because an awful lot of work has gone into the joint health and wellbeing strategy across Berkshire West and similar strategies in Oxford and Buckinghamshire. So this is grossly oversimplifying the work that colleagues have gone into, but it's taking all of the bits that overlap in those strategies and enhancing those to say, well, how can we make a difference if we come together as a wider collective? And I think that's a really important thread. So the benefit to be gained from this new way of working is where it makes sense to do something once and at scale, then it should be easier to do that. But crucially, where it makes more sense to focus on things locally, so either across Berkshire West or within the 3 local authority footprints or further down in terms of neighbourhood footprints, we really want to retain that local focus and that local voice. And one of the kind of exam questions to us as a Berkshire West partnership within the wider system is how do we make sure we are hearing that local voice, that we are hearing the local needs and responding to those appropriately. And if we don't feel that we've hit that mark, then we need to have another look at this. So that's what we're working, the context we're working in and the ambitions that we're aiming for. So the information circulated with the papers gives an overview of the high level areas that are forming the framework of our strategy. These are draft, they're for further input, and I think later today or tomorrow the public engagement portal will be launched, and along with that an awful lot of comms around how we want to engage on this and really get everyone's input into, does this feel like the right thing? Does it feel relevant and local to us? And can we relate to the ambitions in this strategy? So for today's meeting, I wanted to highlight that this process is underway, really encourage members and other colleagues to engage and take some time to have a look at the materials and provide some feedback through those routes or through myself. And ask as well, so in terms of reaching out to the public, not many people will be logging on to the ICB or ICP websites because frankly they don't know about them, and I don't have that many followers on Twitter myself personally in this role. The best way to reach the public is through yourselves and through your organisations. So I know our comms teams are really linked up, but if there is a way or any suggestions that you have of really reaching out to the public on this, then please do feed that back. And I'd also want to formally thank colleagues from West Berkshire for their input into developing this strategy as well. And it would be very remiss of me not to highlight that clearly Councillor Bridgman's very much involved as part of the partnership as well. So he's a direct voice at the partnership table.
Well, thank you. Very busy and I'm going to say exciting times to a very great extent, and at least we now know we have a direct voice into you through Councillor Bridgman, which we will, I'm sure, use as much as we are able. Councillor Macri, you wish to comment?
I had some comments on the strategy and on the emerging priorities. There's 18 priorities. Does this mean, for example, that priority 17, we will reduce and eliminate long waits, comes down below, say, priority 15, we will look after carers? Or are these all equal priorities?
No, so at the moment they're not ranked. But But I think it's fair to say some of the initial feedback that we have had is that 18 priorities is quite a lot of priorities. And so as part of the engagement process, it's understanding whether we need to do a prioritization of the priorities, or if it's more a case of, well, how do we actually get resource behind all of them if we feel that they are the areas that collectively we all need to be working on. And I think it's fair to say that the different places in Berkshire, West Oxfordshire and Buckinghamshire may feel that some of them are more of a priority than others to those areas. And it's absolutely supported to say, well, we're going to focus on the top 5 that feel right for West Berkshire, whilst being cognizant of the others. And so there's that local conversation to be had as well in the context of the strategy.
Can I just add, I was a bit surprised, priority 4, we will take action to address the social, economic and environmental factors that influence our health. I mean, it's something we'd all like to do, I'm sure, but I'm not sure that the health service has really got the wherewithal to tackle that one.
So that's where there's benefits of this being a partnership strategy. So it's health and local authority, and not just the social care element or arm of the local authority. So I think between our organisations, not only are we actually employers, we create employment ourselves, but we have the ability to influence a lot of those sorts of decisions in that sphere. So it's an acknowledgement that this is an area that we are able to influence, and that does have an impact on the wider determinants of health and well-being. And it's something that we need to make sure that we have a strategy around together.
Thank you.
Partnership work is critical in this sphere. Sarah, before I say thank you, Councillor Bridgman, you put your hand up. I was going to say, do you wish to have a final word that you're intrinsically linked into this?
If I may, Chairman, a couple of comments. Firstly, I'm welcoming Sarah aboard because she and I have had a initial meeting, and I'm sure we'll work very closely because certainly I think she and I are singing from a very similar hymn sheet in terms of delivery of the local strategy, which we share across Berkshire West, and in particular making sure the delivery, more to the point, the delivery plan gets delivered, and linking that into making sure there's no particular overlap with the broader strategy, so that the strategy that is coming down from the integrated care system is delivering what we want it to locally, and fits and meshes with what we've got as our strategic outcomes and desires at place level, and even more specifically for us at locality. I had been told that the draft strategy for Bob would be out yesterday. Now I've gone looking for it, can't find it immediately on the website, so I don't know precisely what's going on, but that certainly was the indication we had last week, that it was supposed to be published on the 12th of December. So watch this space basically there. And what I would also say is that Councillor Doherty, leader of council, and I had a very useful meeting with Steve McManus, who is the interim chief executive officer of Bob, having moved from on a temporary basis from Royal Berks, and he's certainly coming at this from a similar angle. The idea that we deliver what we need to deliver at the right level, that there is, in terms of modern phraseology, subsidiarity in the delivery of the strategy, so that what needs to be done at system is done at system, what needs to be done at place is done at place, and so on and so forth, so that we all make sure that what we're doing ties into, to take Councillor Macro's point, the population, this is population health management. So you are looking at the needs and desires of your population and making sure that we are seeking to address them, not simply from an NHS point of view, but as Sarah says, from a partnership of the NHS and local authorities, in particularly first tier local authorities, those with social care responsibilities, housing responsibilities, and so on and so forth, because all of these factors address the health of our population. And it's singling out the NHS and in particular, singling out the acutes, for example, sort of end process care. The conversation we had with Steve was very much, let's see how far upstream we can push this stuff, because the prevent strategy is so important. And we all have a role to play in the prevent strategy so that people don't need health delivery later on in life if we get it right in the early, particularly. And one of the strands in the strategy, you'll see it pervades both the Bob strategy and our own health and wellbeing strategy, is that first 1,001 days. The first 3 years of a child's life is so vital in preventing stuff happening later. So I think we're all speaking with a like mind, and there are meetings going on that there will be further meetings in the new year. I'm meeting with the chairs of the other health and wellbeing boards. Obviously, the ICP is meeting to look at the strategy. So all this stuff is starting to come together. It's taken a while, but these things do. Getting this beast underway is going to take a while and will continue to take a while, but it is moving.
Good. Well, thank you for that. And members, we're asked to note the report. Clearly, this is a fast evolving situation. It seems to be going in a very positive and good direction. And I look forward to hearing more. Sarah, on behalf of everybody, thank you. First of all, I have thanked you for your patience sitting through the previous items, but thank you for your fascinating insight into the great work that you are doing, you and your teams. So thank you.
Thanks.
Thank you. You're welcome.
Members, if I could then go to the Health Watch report. Is Sarah Deason still with us?
Yes, I'm here.
Oh, you're there.
I'm here.
There you are. Welcome, and thank you for your patience too.
Thank you.
Sarah, you're from the advocacy people, I gather, but you can report on Health Watch's current activities and the feedback you've had from some local residents. So yes. Can I ask you to present that to us, please?
Yes, so just to clarify, so the advocacy people are the host organisation for Health Watch West Berkshire and also Health Watch Wokingham and Woking Borough and Reading. So we now cover the Berkshire West patch. The advocacy people is behind the scenes. For the public facing is still Health Watch and so on, but I'm involved at the moment. Just to share that I think you're probably aware that Andrew Sharp has now left Health Watch West Berkshire, and a new lead officer will be imposed by the next meeting. So I'm stepping in the interim. Just to pick up on the one of the discussions just now. One of the things that's coming up as a theme across Berkshire West as well as West Berkshire is the self-care, and so which is what we've been talking about in terms of preventative things, and also in terms of people using the right service at the right time. And we've been talking to people about communications messages about that and getting the message out there as to when it's appropriate to call 111, use a pharmacy, go to A&E, all that kind of theme. So we've been working with different people on that. We've just closed is a Health Watch England survey on maternal mental health, and obviously maternity remains a concern nationally as well as locally. So we'll be keeping an eye on that and looking at what we might want to do locally around that, aside from the maternal mental health survey in conjunction with Health Watch England. And then dentistry, as we've mentioned, continues to be a theme, and that was pretty much it from what I had to say. Thank you.
Thank you. Members, any questions? Councillor Linden.
Yes, Chairman, I just was notified, and a few other councillors were, that we've got a new number, the 116123, to help in mental health crisis, and I think that does need to be promoted, and not only through Sarah and Graham, obviously in their respective roles, but also through Health Watch. And we do need to help not only children's mental health through CAMS, where I know that the MP, Laura Farris, has been involved as the MP of Newbury, but also Health Watch as well. So I just really wanted to throw that into the mix. Thank you.
That kind of crept out, didn't it? It did, really, yeah. Not from you, I mean.
No, quite. But no, we have been notified of that, and certainly I'm sure that we have a role as community champions in our own patches to
publicise it, and the NHS locally, and
which
others,
indeed
and
we will.
media and other people and social media to do so.
Indeed. Sarah, thank you.
Thank you.
Item 10, task and finish group updates. Councillor Macro, this is your spot, I believe.
It is. I can find the
last page.
Yes, we met on the 29th of November, and we had the report from the peer review, if I can pronounce it correctly, which confirmed, I think, what we'd believed for quite a long time, that the provision of continuing healthcare in West Berkshire was significantly lower, and one of the worst ways, if I can put it that way, than lots of the other areas of the country, and compared very unfavourably with other parts of the integrated care system. In particular, I think Buckinghamshire was an exemplar. But also there's an ongoing review into provision of CHC in West Berkshire, which we got the distinct impression was not regarded as very high priority by the health service. We really need to keep an eye on that and meet again, and that looks like it might be coming to a conclusion. But I must give my thanks once again to Paul, because he basically provided most of the input to that, apart from the peer review report itself.
Okay, Sarah, you have your hand up. Welcome back.
Hi. So just on the CHC review. So obviously we've had the peer review and the feedback there. There's a transformation programme running across the Bob footprint, looking at a number of areas, of which CHC is one of them. So looking at what our future CHC model of provision might be, how we address imbalances between the three areas within our footprint. And a few other areas, but crucially for us, we've also been having some local conversations in Berkshire West, myself and the directors of adult social services, Paul and some other colleagues, to see what can we do quicker now and locally. So there's a few areas that we're working on that we're expecting updates on in January, and I've been doing a lot of work to push those timeframes internally as quickly as we can do. So I do hope that we will see some movement in a positive direction.
That sounds a bit more positive, thank you.
I like positive, that's good, thank you. Members, item 11 is the work programme, which is on the last page of our agenda. I think this is really just to note, is it not? Next meeting, 14th of March next year. I think this is just for us to note, is it not, Vicky?
Yes, and invite members if they've got any other suggestions to say
Always.
them today.
Absolutely. If you have other suggestions, please notify Vicky. We will add them to the work schedule. Members, is there anything? Yes, Councillor Macro.
I can't remember how the priorities go. So is the priority
low?
Is priority 8 higher priority than
Than
priority
12?
10? No?
Lower, the higher the number.
Right. Because I'm wondering whether we ought to try and increase the priority of blood tests. There's certainly a problem in my area with, I think, the last phlebotomist has just left the general practice, and to get an appointment to either, well, certainly at the West Berkshire Community Hospital can take a very long time, and I think it can take some time at Royal Bucks as well.
Oh, well, it must be very patchy, because certainly in practice I attend, there is much less of a difficulty, I'm led to believe. But could we look at that one, Vicky. I mean, clearly there are, if an individual leaves, then that leaves a big gap, does there not? So I take
Well,
that right.
they had two, and then
Yes, yeah.
None.
That doesn't help.
No.
Councillor Linden.
Yes, GP numbers.
Yeah.
Pharmaceutical, because obviously we're discussing Thatcher here, but elsewhere.
Yes.
But of course, refugees and asylum seekers, we have quite a number, and we need to make sure they're looked after, Sharon. And the other thing I was going to ask was that our myself and yourself, my revisit, because I sticking cold at the time, onto the RBH, our site visit. So I just thought I'll mention that, Vicky. Then because I'll be seeing the person responsible for that rebuilding tonight at Tyler's Parish Council. So that's it.
Oh, okay.
Ali Foster,
Okay.
so who's a parish council. But did you have an update?
I don't.
Okay.
We'll provide you one, I'm sure. I do accept what you just said about pharmaceutical provision. There certainly have been issues in Thatcham that I know of, where a certain chain of chemists has been, I believe, having difficulty recruiting pharmacists. And I think that should be a fairly high priority, because there are people who relied heavily on deliveries of medication because they're unable to access the shops very easily themselves. And it has caused quite a few issues. So I think that should be something that is a high priority. Although I'm hopeful that the provision will be returning to as it was, or more as it was, after Christmas. Councillor Bridgman, you have your hand up.
Chairman, if I may, the question of pharmacy provision was discussed at some length at Locality Integration Board, and Paul co-chairs that board, and therefore he'll know the discussion that went on. And we had a very useful presentation from Pharmacy Thames Valley, who I would point you in their direction on anything pharmaceutical related. And it was a useful discussion about the issues that had arisen in Thatcham in particular, not although I have to say it's not just Thatcham, there have been a few issues elsewhere, but Thatcham was the one that really caught the headlines. So I just point you at Pharmacy Thames Valley as a useful source of information.
I'm grateful. Perhaps I should have spoken to you beforehand. My apologies. I mean, Paul, there's nothing you wish to add at this time.
I would agree entirely. It was very useful. I mean, I think it was a difficult message. Efforts are being made, but it's a very tough landscape that they're operating.
I'm sure it is. I know. I understand that. Councillor Macra, is that a legacy hand?
Oh no, actually, just jolted onto this one by Tony. The visit we made to Royal Berkshire Hospital, I think that I'd like to extend my thanks to the hospital if we could do that through Graham. It's a very useful visit. The situation, I mean, I've always had my doubts about that hospital, shall I say, in terms of its physical fabric. But I think we learned a lot, and there was things were in some places a far worse situation than I thought, particularly cancer care and the pharmacy. I mean, it seems to have a room about twice the size with dozens of people and shoots of things coming in, and it seems to be. I think they're heroes. I think working.
Well, yeah, quite impressive.
So I'd like to stuff. If you could extend my thanks to the hospital, please, Graham.
Absolutely. Graham Bridgman.
Yes,
yes, absolutely. If you would, and I look forward to visiting them as well. It's many years since in my Community Health Council days since I have visited. So I look forward to the next visit and being involved. Councillor Moore.
Well, I'm just going back to the pharmacy thing, noting that in the programme we didn't have anybody to speak to, but at least we've now got a reference. But Graham, can I ask what is Pharmacy Thames Valley? What sort of body is that?
As far as I'm aware, NHS in a similar. You've just been discussing dentistry and that sort of dentistry across the Thames Valley, very much. And I'm hoping Sarah and Paul will both nod at me. Very much, that sort of overarching NHS commissioning pulled together for pharmacy services in that vicinity.
Okay, thank you.
So you're getting a nod from Sarah, that's good. I can't see Paul nodding.
Yeah, I'll agree. Yeah.
He'll agree, there you go. That's as good as a nod. I think we're done. May I thank everybody for their input. I've learned a lot, and thank you for being gentle with me for my first meeting. I look forward very much to the next one in March. I wish you all a very happy Christmas, happy and prosperous and hardworking 2023. And I'm delighted to see so much good work going on and on track, particularly, Sarah, with the work that you have reported on. Thank you indeed. I therefore close the meeting, and could I please ask for when we are closed off from our Zoom meeting?
Much we're clear, Chairman.